Good evening. Good evening, Chatham-Kent. Hi, everyone. It's Phil coming at you from the Prosperity Roundtable. For those who don't know me, my name is Philip Mock, and I'm the project coordinator for the Chatham-Kent Prosperity Roundtable, a local initiative building communities up and looking to reduce poverty. I'm very, very excited to be here again tonight, doing another live session with you. Tonight, we are here for a little bit of a different reason than I've been here in the past for. Tonight, we are here to talk about what we know about substance use. We have a community panel discussion for you that's going to cover four main topics: prevention, treatment, harm reduction, and community safety. But that's enough of me blathering on. I'm going to turn over to Brad Davis, who is the chair of the Chatham-Kent Drug Awareness Council, for a quick introduction. Brad, take it away.
Okay, thank you, Mr. Mock, and I will be very brief. As Philip said, I am the chair of the Chatham-Kent Drug Awareness Council, and on behalf of the council, I just want to thank everyone for being here this evening as we engage in a discussion around substance abuse. For those of you who are joining us online as interested members in our community, it's great to have you here. We hope that tonight's discussion will be valuable. And with that, Philip, I want to be mindful of time and turn it back to you to introduce our panelists. Thank you.
Perfect. Thank you so much, Brad. I really appreciate your time. I'm also going to turn over to Darren Trainer, who's joining us as well, to do a land acknowledgement before we get going. Darren.
Hi, guys. As we enter our presentation, we acknowledge that our community of Chatham-Kent resides on traditional territory. This sacred land is subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and Confederacy of the Ojibwe and allied nations to share and care for the resources around the Great Lakes. As we gather today on these treaty lands, we have the responsibility to honor and respect the four directions: land, waters, plants, animals, ancestors that walked before us, and all the wonderful elements of creation that exist. It is important to understand the long-standing history that has brought us here today and to understand where we fit amid that history. Land acknowledgements do not exist in the past tense. Colonialism is a current and ongoing process, and we need to be aware of our present involvement. We are presenting from the area now known as Chatham-Kent, but recognize that folks might be joining us from other communities, so we wish to acknowledge everyone who's joining us today and their culture, history, and identities. We recognize that conversations around substance use cannot happen without engaging Indigenous communities. The voices of Indigenous peoples are central to this work, as Indigenous communities are significantly overrepresented in substance use harms and overdose-related deaths. We understand these conversations will be uncomfortable and the work will be hard. We are committed to showing up imperfectly to listen, learn, and unlearn. Lastly, we recognize that land acknowledgement alone is not enough. Acknowledgement is a starting point as we work towards reconciliation. Please take a moment to reflect on how you plan to take action to support Indigenous communities. Thank you very much.
Thank you very much, Darren. And I have to say, I really appreciate how it's not just a land acknowledgement, you're taking it further, that there's acts of reconciliation we can engage in. I really appreciate that next step that's so important as we move forward here. Thank you very much, Darren. I'm now going to turn it over to some presenters we have. We have four amazing presenters here tonight. They each are going to present a little bit on their respective topics of prevention, harm reduction, treatment, and decriminalization. And I'm going to introduce them now because you can't have presenters jump on without a good introduction. So I'm going to start by introducing Jordyn Lindsay. Jordyn is a registered nurse working in public health in the field of mental health and substance use. With a passion for social justice and health equity, Jordyn works to integrate principles of trauma and violence-informed care, cultural humility, and intersectionality in all aspects of her work. In her public health role and as a volunteer street nurse, Jordyn aims to engage, support, and empower individuals and communities marginalized by systems of oppression. including those most impacted by the drug poisoning crisis, war on people who use drugs, and criminalization of substance use as an ally and advocate for upstream and action-focused solutions. Jordyn, are you able to join us? I'm not sure if she's still on the feed. And if not, that's okay. I'm gonna jump on to our second presenter, who will be presenting tonight. I'm going to be introducing Steph DeVitto. Steph is the clinical supervisor for outpatient mental health and addictions programs at the Chatham-Kent Health Alliance. Since 2013, she has held various roles in both inpatient and outpatient mental health and addictions programs as a social worker and therapist. She was involved in the organization and planning process for the CKHA RAAM clinic in 2019 and has been most recently involved in the implementation of the CKHA Residential Withdrawal Management Program. Steph is passionate about improving client access to mental health and addiction services, and ensuring that the client and family experience is kept at the core of the services we provide. Steph, it is great to have you here tonight. Thank you for joining us.
Thanks, Phil.
Absolutely. Another panelist we'll introduce as well is Scott Roose. Scott is joining in 2018. Scott has been a member of the Chatham-Kent Drug Awareness Council as a person with lived expertise. As a storyteller, he shares stories of loss, addiction, HIV, stigma, and the continuing journey of recovery. Harm reduction, along with advocacy for the homeless, has been his passion for bringing awareness to the cause and preventing others from experiencing the whip of stigma in today's challenging times. Thank you so much, Scott, for joining us.
Thank you.
Absolutely. And certainly, last but not least, our last panelist of tonight, Chief Gary Conn with Chatham-Kent Police. Chief Conn has been a police officer for over 27 years and has worked in most areas of the profession, having been our chief of police for just over 7 years now. He is an advocate for lifelong learning and has completed his bachelor's degree in sociology, a master's degree in public administration, and his doctorate degree of education, all from Western University. He is also a distinguished graduate from the FBI National Academy, Session 258, where he further obtained a graduate diploma from the University of Virginia in criminal justice education. Finally, Gary is a board director for the Chatham-Kent Women's Center and sits on the CACP, which is the Canadian Association of Chiefs of Police, Use of Force Advisory Committee. He is also a co-chair for the OACP Justice Committee, a co-chair for the Chatham-Kent Community Safety and Wellbeing Steering Committee, and is currently the president for the OACP, or the Ontario Association of Chiefs of Police. Chief Conn, it's great to see you here tonight. Thanks for joining.
Likewise, Phil. Good evening, everyone.
Perfect. Our first panelist for tonight was going to be Jordyn Lindsay. Unfortunately, she's having some technical difficulties, so we're gonna shift into a second gear here, and I'm going to turn it over to Scott Roose, who's going to come and speak to us a little bit more about harm reduction. Scott, thank you again for joining us. I'll turn it over to you, and I'm just going to pop in the background, and I'll be back in when you're ready.
No worries. Thanks, Phil. I appreciate it. So as Phil mentioned, I'm going to be talking about harm reduction tonight. Harm reduction in itself is places paramount importance on the sacredness of life. That was a quote from Landon Hindlebrand. He's the director of housing and clinical development at the Mustard Seed in Edmonton, Alberta. I want to start off with a question. It's a little bit of trivia, so you're going to have to put your thinking caps on. Now, January 1st, 1976 is a big important date in Canadian law. Chief Conn, I hope your ears are perked up there. What was mandated for all adults in Ontario on January 1st, 1976? Some people spoke afterwards about this mandate, and one woman was quoted. She said, "I just hate them." She's asked why she refused to put one on. I think I hate them because you have to wear them, and I think it's more of what you've got to wear than when you don't. I think whether you're male or female, it's a dominance thing, replies a man then next to her. I'm in charge. Don't tell me what to do. Can anybody tell me in the chat what was mandated in 1976? Now, I can't see the chat. Becky, she got it right on the nose. First question, first answer out. It's seatbelts. Seatbelts, as you can see, is a safety mechanism for your car. It's a part of a form of harm reduction. You've been using it since 1976. Now, those quotes, I'm gonna have to come straight with you guys. Those quotes weren't from 1976. They're from 2020 for the mask mandates for wearing masks. So sometimes we can tend to repeat ourselves. Now, what is harm reduction? So harm reduction is the practice of reducing the harms associated with drug use and meet the person who is using drugs where they're at in their journey to recovery and give them the tools they need to be safe. Harm reduction is an evidence-based approach in the complex issue of drug use worldwide. Harm reduction is not enabling the person using drugs. Harm reduction starts well after the point that the person has decided to use drugs. This is a radical approach because, in effect, harm reduction says we will do our best to reduce the impact on the harm that can occur from substance use by giving them the tools they need to ingest the substance. If you've heard me speak in the past, you remember the line, no one ever grows up wanting to be a person using drugs. The principles of harm reduction. Now, people who use drugs are not their addiction, and they deserve to be treated equitably and humanely. People who use drugs have been the subject of a 50-year-long drug war based on discrimination, stigma, and misinformation. Harm reduction is a philosophy of care. It's a way that we treat people as service providers through the toolkit that I'm going to mention later on in my talk. The fundamental idea of harm reduction is that drug use is something that is part of society. We all seek dopamine, and some people just have healthier options available to them. Some people choose to go out to a bar to relax. You're using a supervised consumption site and a regulated safe supply. Harm reduction ensures that we have the opportunity to make the healthiest choice possible. So what's in this toolkit that I just mentioned? So some of the big things you've probably heard in the news lately is supervised consumption sites or an overdose prevention site. So what are they? So they're services that are used to save lives and benefit communities. They provide a safe and clean space for people to bring their drugs to use in the presence of trained staff. This prevents accidental overdoses and reduces the spread of infectious disease, such as HIV and hepatitis C, and provides an additional point of contact for the person who's using the substances to get connected to withdrawal management supports, RAAM clinics, and MAT. Supervised consumption sites may offer a range of evidence-based harm reduction services, such as drug checking. These sites also provide access to important health and social services, including substance use treatment for those who are ready. Overdose prevention sites differ from supervised consumption sites because the primary goal of an overdose prevention site is to prevent and respond to overdoses. In a non-overdose prevention site, peers or other typical non-nursing staff can monitor people who have used drugs for signs of overdose. Supervised consumption sites are facilities that have been exempt by Health Canada under the Controlled Drugs and Substance Act. Next, we have needle exchange program. You've probably seen the big yellow bins that are outside the Wish Center. Those are where you put your used needles so they can be safely disposed of. But in 1983, John Steuben Parker, a Yale student and former heroin user, began to publicly distribute sterile needles to intravenous drug users in the New Haven, Connecticut. Now in over 90 countries, needle exchange have been at the forefront of basic harm reduction policies. A needle exchange program, an SP, also known as a needle exchange program, an EP, is a social service that allows injecting drug users to obtain clean and unused hypodermic needles and associated paraphernalia at little or no cost. The next thing that we have in our toolkit is medication-assisted treatment, or MAT. Now, this refers to any treatment for a substance use disorder that includes pharmacology intervention as part of the larger, more complex addiction treatment plan. It involves the use of medications approved by Health Canada in combination with education, counseling, behavioral therapies, and peer support to provide a comprehensive, evidence-based approach to care. We've just opened this recently, not recently, it's 2019, I believe, our Rapid Access to Addiction Medicine Clinic, our RAAM clinic. These clinics are a low barrier walk-in clinic that patients can attend to and get help for their substance use disorder without an appointment or a formal referral. RAAM clinics provide time-limited medical addiction care, including pharmacology, brief counseling, and referrals to community services. Rapid Access Addiction Medicine provides comprehensive physician in addition to counseling-led programs managing all substance use and behavioral addiction concerns. And last but not least, on our toolkit, we've got mobile outreach services. The United Way just started a mobile outreach van, the Van with a Plan. This allows community partners to use this van as they see fit for serving the needs of their people. And I know one of the groups, Rock Missions, uses it for their outreach services, needle exchange, and for food, to deliver food. This has been a game changer for Rock Missions. They now can make sure that all of their friends that are on the street get taken care of, have the things they need, where they're at, and make sure that they're fed. So what needs to happen now? One word. It's only one word. We need to change. The status quo is not working. Old attitudes and tough love and the war on drugs is not working. We need to stop the structured violence against our most undervalued, misrepresented, marginalized, and frankly, would disappear group of people. I have one thing to say about that. We're not going to disappear. So how do we go about creating that change? First, as a society, we must accept that drugs are a consequence of our modern human condition. Everyone, and I mean everyone, wants to escape their emotions at some point in their lives. It is unfortunate that some of us have healthier choices available to them. Now, what about drug users as a whole? If you try drugs, you're automatically addicted. No, the evidence points to a 20 to 40% use conversion to people that are addicted. So those are the 20 to 40% most vulnerable, most marginalized, most stigmatized people of our communities, and we need to help them. So I've covered quite a bit of things in our toolkit that we have. The one thing that we can do on our own to make sure that we're taking care of people that are used substances and people that are homeless and things like that, we can change our language. Stigma is one of the biggest things that is a barrier to getting health, to getting supports, to getting all the things that are necessary to beat this problem. Just watch your words. Make sure that it feels good to use them, not something that you're thinking, ooh, that's not a good thing. And lastly, I thank everyone for coming tonight, and I look forward to your questions later on in the program. Thank you.
Thank you so much, Scott, for that really passionate and actually very informative presentation. I've been taking like copious notes as we're sitting here and you're talking. I really appreciate how you went through the tons of different ways communities can support harm reduction. It's not like a one-size-fits-all model. There's multiple different tools in the toolkit, as you put it. And I really appreciated your opening. Thank you very much for reminding us of the way we need to think and the way we need to act and treat people in our community who are living with substance use and addictions. So I really appreciate your time. Thank you very much, Scott, for your time. As Scott mentioned as well, any questions you have, any thoughts, please comment below. We're going to have a question period after the presentations at the beginning. So please, questions and comments below in the comment section, and we'll get to them right after the presentations. Thank you again to Scott Roose for speaking to us about harm reduction. I'm now going to turn over to Jordyn Lindsay. And Jordyn, I promised I gave you a great bio introduction. I'm so glad you could join us again. Jordyn, you're here to talk to us about prevention. So I'll turn it over to you for your presentation. Thanks for coming.
Thanks so much, Phil. So thanks everyone for joining us for this conversation tonight. I'm so excited to learn and talk with you all. The information that I'm sharing today on substance use prevention is shaped by my experience over the past 4 or 5 years working with the Chatham-Kent Drug Awareness Council, and it comes from a public health perspective. And I can't begin without acknowledging the countless lives of individuals, families, and communities that continue to be affected by the drug poisoning crisis and the war on people who use drugs. The voices, decades of work, and contributions of people who use drugs and their families and friends are absolutely vital to this work. And if it wasn't already mentioned before, conversations about substance use can be really difficult for many reasons. So please do what you need to self-manage throughout the presentation and reach out to someone you trust for support if needed. Next slide, please. What if I were to tell you that we have the ability to stop a toxic drug poisoning, heart disease, substance use disorder, motor vehicle collisions, lung cancer, incarceration, fetal alcohol syndrome, and costs to the healthcare and criminal justice systems decades before these health and social issues occur? Prevention is possible, and we have the knowledge and tools to stop these harms before they ever come close to the devastating realities we so often hear about and experience today. There are countries and communities around the world that have accomplished this. Strategies to stop problems before they occur are based on research evidence, but also have a lot to do with common sense. And today I hope to give you a very brief introduction of where we can start. Next slide, please. And backing up just a little bit, the 4 pillars, prevention, harm reduction, treatment, and community safety, really provide a foundation on which to build a comprehensive community substance use strategy and are widely used in communities across Canada and around the world. These pillars are not discrete concepts, but are interconnected and really work together to address a range of complex substance use related harms by building partnerships with people who use drugs, families and friends of people who use drugs, frontline service providers, and decision makers. Next slide, please. Substance use is deeply embedded in our cultural fabric. People have been using a wide variety of psychoactive substances, both regulated and unregulated, for thousands of years. The reasons we use a substance and the context within which substances are used influence our risk of harmful consequences. From a public health perspective, there is a level of risk associated with any type of substance use, but there's also opportunity to lower risk without necessarily reducing or stopping use. So an important truth to recognize is that actually the vast majority of people who use substances do so without significant negative health or social outcomes. So there's also many benefits associated with substance use. For example, caffeine use to increase alertness, ceremonial tobacco, or prescription medications to treat an infection. So there's an important place for substance use, and that's really essential to acknowledge for a balanced understanding of substance use. It's very complex. Each person experiences substance use health differently. And the goal should really be not to label a person's substance use, but rather help individuals self-assess and identify their relationship with a particular substance as a starting point for conversations about how to balance risk and benefits. Next slide, please. When we talk about substance use prevention, we often think about just say no approaches and youth education campaigns, things like that. But there's much more to prevention than that. From a public health standpoint, substance use prevention is a range of approaches and strategies and interventions which involve promoting health opportunities for well-being in all aspects of a person's life, mental, spiritual, physical, emotional, and social well-being, preventing risk factors that we know contribute to substance use, delaying substance use. So we know the later a person engages in substance use, the less likely they are to experience harms, and reducing harms associated with substance use. So accepting that substance use is a part of human existence and promoting ways for people to be able to use more safely. Prevention work also extends far beyond public health. It happens every day in schools, in early childhood education, parenting, caregiving, prenatal care, housing, nonprofits, mental health, children's services, research, government, just to name a few. There's many, many people and organizations that do this work in our community. Next slide, please. Public health advocates often talk about this analogy of a river or a stream, which is based on an old parable. And it's about a couple fishing on a riverbank, and when they see a person come by that's struggling against the current and is drowning, and they quickly jump in the river to rescue them. Soon after, they see another person struggling in the river, and they jump in to rescue that person. And this continues all day, and finally, the exhausted pair look at each other and ask, who keeps pushing these people into the river? And they decide to go upstream and find out why so many people are falling in the first place. So upstream approaches seek to understand and address the root causes of a health issue. And this requires attention to social justice and health equity. It means acknowledging the complex circumstances that impact people's actions and abilities. And when it's done right, upstream prevention is essentially invisible. We don't experience the negative outcomes or harms that we're trying to prevent. We address the root cause so people never have to fall in the river and be rescued. Next slide, please. And if we ask this question in terms of substance use, we're not likely to get a simple or straightforward answer. It's a bit like a giant iceberg. There is no single cause. There is no one reason that people fall into the river. Substance use is shaped by a complex interplay of risk factors in each of these domains. And often the most visible risks of substance use are just the tip of the iceberg. There's always more beneath the surface. And upstream prevention requires us to address the causes of the causes. The deeper we go, the more difficult these risks are to identify and solve, because we're working to change entire systems that are deeply entrenched in the structures of our society and how our society works. Next slide, please. Stigma in particular is a really important factor and harm to highlight, as Scott mentioned. Stigma is something that the Drug Awareness Council is working to end. It's any attitude, belief, or behavior that discriminates, belittles, or shames people. It causes trauma and feelings of worthlessness and exclusion from society, and it prevents people from seeking help and affects how services are provided. And studies have shown that people who use substances are among the most stigmatized populations. A more compassionate perspective of substance use places the focus on the person rather than on the substance. And a person-centered approach can help us better explain real-life situations that don't neatly fit into a one-dimensional view of substance use as a personal choice or moral failing. Next slide, please. And substance use is challenging because it really does not discriminate. It affects people from all walks of life. However, research has shown that these risk factors and substance use related harms, in particular stigma, have disproportionate impacts for certain groups. And this really means that our prevention and drug strategy work should promote health and well-being for all individuals in our community and specifically support groups that are more vulnerable through approaches that are developed by, with, and for them. Next slide, please. And just as important as looking upstream to figure out what's causing folks to fall in the river, we also need to understand what protects people from experiencing substance use related harms. We know that when people's basic human rights are met, when they have connections to support and healthy relationships, that they are far less likely to use substances. And if they do, they're less likely to experience harms. So in other words, a drop of prevention upstream that builds protective factors, that addresses those determinants of health, income, housing, education, it can create ripples of positive impact across communities. Next slide, please. And this whole idea of upstream prevention, strengthening these protective factors and mitigating these risk factors, it's been proven to work. In the 1980s, Iceland's youth was engaging in substance use at rates that were significantly higher than most other European countries. And a group of researchers came together with government, with community leaders, schools, and parents and caregivers, and collectively they worked together to learn about why youth were engaging in substance use and to develop community solutions to challenge and change these norms. So they developed programs to build healthy environments for positive youth development by reducing risks and building strengths within families, peer groups, schools, and in the community. And actually today, Iceland tops the European table for the healthiest living youth and young adults. Rates of substance use, vandalism, theft, violence, and abuse have all decreased significantly. And furthermore, youth who do not use substances throughout adolescence are found to continue healthy behaviors into adulthood. There's also data that suggests that the same protective and risk factors identified in Iceland apply to other locations and in different cultures, from places as far as the Faroe Islands, Romania, South Korea, and Nairobi. These positive findings suggest that the Icelandic model can be used and adapted to meet local needs. Next slide, please. And just lastly, I'll end with this past couple of years has been especially tough for everyone in our community. So if you or someone you know are experiencing a mental health or a substance use issue, you are not alone. Support is available. These are just a few examples of supports that are available in our community. Please reach out. There's lots of information on the Chatham-Kent Drug Awareness Council website. Thank you.
I'm not used to unmuting myself and muting myself again, so apologies, everyone. I just want to say, Jordyn, thank you so much for your presentation. I really appreciate that the comments you made about prevention and the fact that prevention, there's no easy one fix solution. It's not an easy solution. These take time, but the systemic changes, while complex, takes a community to come together to try and fix. So I thank you so much, Jordyn, for your presentation, for sharing those resources at the end there, for anybody watching who would like to share those with family or friends or just the community at large. Excuse me. I'm now going to turn it over to Stephanie DeVitto, who's going to speak to us about treatment and is going to speak to us specifically about the Rapid Access to Addiction Medicine, or RAAM clinic. Stephanie, over to you.
Thanks, Phil. I'm so happy to be here tonight to talk to you guys about treatment options for addictions. So tonight we're going to be focusing mostly on the RAAM clinic, as a couple people have mentioned already, but I also wanted to just overview some of our other addiction services that we also have. So starting with, and you can go to the third slide there. So we have our mental health and addictions program, which is commonly referred to as MAP. Or MHAP, depending on which agency you work for. But this is the longest standing service that we've had at CKHA. And what we offer through that service is addictions therapy for up to 12 sessions. So that would be weekly, bi-weekly, depending on the treatment plan, sessions with a therapist who's trained in mental health and addictions. We also offer through that service therapy for significant others. So family members of individuals who struggle with addiction, or anyone who kind of terms themselves as family. And as we know that it is very difficult to support someone who struggles with addiction. So we offer that service as well, up to 12 sessions in the same format. Our second service is our withdrawal management service, which is a brand new program to CKHA and to Chatham-Kent. We just opened March 15th, 3 interim beds on inpatient psychiatry. That's, again, an interim plan until we can open our full 10-bed unit in, we're aiming for June of 2022. So that will be a much needed, or is a much needed service in Chatham-Kent that we are currently operating. And then lastly, just a quick summary of the RAAM clinic. So we offer drop-in service, addictions medication, brief therapy supports, referral to treatment, and treatment planning. Next slide, please. So the RAAM clinic was designed to be, it came out of kind of research and feedback from clients that a lot of addiction services weren't meeting clients where they were at. So long wait lists, not able to get into service. Maybe the motivation to make a change was there, and then by the time they get services, they're in a different phase of life and they're not ready to pursue that anymore. So the RAAM model is designed to be low barrier, walk-in, and patient-centered to address the holistic needs of clients that are coming through our doors. So we're open Monday, Wednesday, and Friday from 12 to 4 for drop-in, and Thursdays by appointment only. We're located at 240 Grand Ave West in our mental health and addictions program location. It's in the same building as CMHA, if anyone's familiar with that. We're on the second floor, Suite 204, and that's just until June 2022. So in June, our withdrawal management and our RAAM clinic will be together in the hospital in Zone F, which is on the ED side of the hospital. So we're really excited to have those services together, and we've done that to increase communication between program and access to addiction services. We also have a Wallaceburg RAAM clinic that we recently opened, and that's open Tuesdays from 12 to 4 at the Wallaceburg hospital site. Next slide, please. So the RAAM staff provides support to any individual who identifies as needing support for their substance use. Our current staffing consists of a registered nurse, an RN, a therapist, an addiction psychiatrist, and all 3 of those individuals are always there on a RAAM clinic drop-in day. An individual may meet with each staff member or just some of them, depending on the goals that they present with. So again, we really try to focus on where the client is at. If they're there for harm reduction supplies, if they're there for support from a therapist, they can see the therapist that day. If they're not ready for a full assessment, then we do whatever we can to provide them support. We do try to look at, if this is the one time they walk through our door, how can we best support them in order to that one time hopefully make some sort of difference or change in their life. So yeah, we try not to do too large of an assessment process. Next slide, please. So when an individual comes to RAAM clinic, they'll meet with the RN or the therapist, depending on who is available, to complete an assessment. So if they write on their paperwork a certain thing, then the nurse might take them first, or the therapist might take them first, but it really is just whichever staff is available. Our RAAM clinic can get quite busy. You know, sometimes we're serving up to 15 clients in a 3-hour period. And so it's pretty much just kind of first come, first serve, whoever's next available to come and grab that client from the waiting room to meet with them. So based on the individual's needs, the services that can be offered are addictions medications, brief counseling with the therapist to work towards whatever goals the client is identifying, an appointment to complete a gains assessment for referral to inpatient treatment for like longer term addictions treatment. And the gains assessment is the formalized addictions assessment in Ontario. So a lot of treatment centers across the province require a gains assessment to complete. So our therapists at the RAAM clinic are trained in the gains. We could provide at the RAAM an assessment for withdrawal management services to see if they're eligible for that, or if that's what they're looking for. And the reason someone might want withdrawal management services would be if their level of withdrawal is higher than we can manage on a community level, if they're looking for a safe place to withdraw from substances. Yeah. We also provide access to harm reduction supplies that we get through public health and through positive pathways. And so we provide naloxone, needles, pipes, pretty much any harm reduction supply that that's offered at other locations. We can provide referrals to ongoing mental health and addictions therapy, and we can do that quite well considering that they're both of our programs. So sometimes it will be the same therapist that is at the RAAM clinic that day that will pick up the client in our therapy program, or it would be referred to one of the other individuals in our therapy program, one of the other therapists. And we can also facilitate a referral to psychiatry for mental health concerns. If they have a family doctor, then we'll get them to access that resource to keep everyone on the same page, but we do try to help facilitate those connections. And we also will partner and refer with community agencies to assist with the presenting issues that are going on. So Ontario Works, if an individual identifies as precariously housed, then we can try to assist them with housing services. We work in a very close partnership with the CMHA Addictions First Response Team. So if an individual is needing more support in the community, since we currently don't travel outside of the building, then we will refer to the First Response Team and work in partnership with them. And they also bring lots of their clients to the RAAM clinic when they're feeling like they're ready for our treatment options. And also with Rock Missions. I just mentioned a few here, but there's so many community agencies that we partner with, to ensure that we're kind of meeting all of the clients' needs in a holistic way. Next slide, please. There we go. Addictions medication. So the RAAM clinic can provide community. I just talked about our bedded withdrawal services, but we also since the RAAM clinic has been open, which has been a couple of years now, we provide community withdrawal to individuals who are low risk and do not need the support of a bedded withdrawal management program. So what will happen is that the client will be provided the medication that will assist them in the withdrawal process and asked to return the next day and ongoing to support their symptoms. Depending on the substances used, there are medications to assist with the withdrawal process as well as to manage cravings. We recommend that the client meets with all members of the RAAM team. The research supports that medication can help to control physical cravings, which makes patients or clients more able to participate in counseling, and counseling helps patients get to the root of their substance use. And we try to address from a trauma-informed lens what's going on for the client. And so we often find sometimes people are more focused on medication, sometimes more focused on therapy, and we will respect that, but we really encourage kind of exploring all of our services and how we can help. Next slide, please. So I won't review all of them for the sake of time, but just kind of a short, there's medications for alcohol, the benzodiazepines is for the withdrawal process, naltrexone, acamprosate, and gabapentin can be used for withdrawal symptom or for craving, and then for opioids, we have Suboxone is our most popular, or what we use to treat opioid addiction. And we also offer Sublocade, which is the injectable form of Suboxone, is a monthly injectable. For stimulants like crystal meth and cocaine, there's no current evidence-based treatments for cravings related to this stimulant use. Our psychiatrist will assess for symptoms of ADHD and consider kind of what's in the process for being used for these substances. But that's kind of based on each individual situation. And then for addictions to benzodiazepines, that would involve a longer-term benzodiazepine treatment, as that is the best practice. Next slide, please. Once stabilized, clients can go for longer periods of time. So it's really based on what the client need is. So if they only need to come once a month to check in with us, that's great. If they feel that they can be adequately served by their family doctor or by other services, that's great. But if they'd like more check-ins, they can drop in whenever to talk to the therapist within our hours. They are discharged from our program once they've been inactive for a month, but then they can present again as needed. Next slide. So just as my last summary there, I think the last slide isn't popping up, but there we go. So anyways, in summary, the clinic is low barrier, patient-centered, and we really try to meet the clients where they're at. Thank you very much.
Well, thank you so much, Steph. I really appreciate that presentation. The RAAM clinic is something that, as you mentioned, has been started for a couple of years now, but not a lot of people might know it exists and where it's located, what it offers. It offers a variety of different services. I was trying to catch up and keep all these notes going, and there's a lot that the RAAM clinic offers. So I'm excited to come back to you with more questions because questions are coming up to us about it. So we'll come back after Chief Conn's presentation. Thank you so much, Stephanie. And now I'm going to invite Chief Gary Conn to join us. Chief Conn is going to be speaking to us about decriminalization. And so just in the effort of time, Chief Conn, I'm going to turn it right over to you and you can jump into your presentation.
Thank you, Phil. And before I get started, I just want to thank you for having me this evening, and also a thank you to Steph, Jordyn, and Scott for their very informative presentations. I took a little bit from each of them, and I also want to thank them for the services and support that they provide to the citizens in our community. That being said, I guess we'll start with my PowerPoint if you want to bring it up. Super, thank you. So decriminalization. Decriminalization, well, obviously a very pressing and contentious issue currently, right now. So I think the first slide, what we need to solidify is what is, the definition and what exactly is decriminalization. I'll try to be mindful of our time, so I'll try to blast through these slides so that we have more time for Q&A afterwards. But decriminalization in its basic, simplest form removes basically criminal sanctions for possession of small amounts of drugs for personal use. Decriminalization is not legalization. I want to emphasize that point because I get quoted quite a bit in the media and that, and sometimes they quote me incorrectly. So I'm hoping that it gets when you see it, you can read it and it's clear and crystal. Illicit substances would still remain illegal under the federal law. Criminal penalties will continue to apply for trafficking, exportation, importation, organized crime, no matter if possession amounts are above or below the threshold, like for simple possession of 30 milligrams. And that's a good thing because obviously it'll allow us with decriminalization to concentrate more of our resources and effort towards those more egregious offenses of trafficking, exportation, and importation, and obviously organized crime. Decriminalization is not directly linked to safe supply, although it is intended to remove barriers to accessing safe supply, treatment, and obviously harm reduction services. Next slide, please. So now that we know what decriminalization means, I'll just give a quick snapshot as to the drug offenses and issues that we're currently facing locally here in Chatham-Kent. So yes, you know what? These are unprecedented times, and having to deal with COVID and the COVID crisis, Omicron, a very pressing issue. But during that same period of time, we have been also dealing with an opioid crisis. And as you can see locally here, this graph depicts the overdose deaths, either accidental or otherwise, that we, CKPS, have responded to. Now, the opioid deaths in our municipality are actually higher than those depicted numbers, but those are what we have responded to on an annual basis over the last 4 years. And as you can see, it has grown exponentially over the last 4 years. Next slide, please. Drug offense calls for service. Now, this chart here, it depicts the total amount of calls for service that were classified as drug offense calls. But I want to clarify that this does not depict the total amount of calls for service that our entire service has responded to in regards to drug offenses. This is just the calls for service that our specialty unit, our drug unit and intel section have responded to. So you can see it's remained kind of consistent over the last 4 years, but certainly the last 2 years, it's been around the 500 to 600 calls for service. Next slide, please. Finally, this chart depicts locally here the total amount of drug charges. Once again, just our drug enforcement unit has laid. This does not account for the charges that have been laid by any other section in the Chatham-Kent Police Service. So for example, our largest section being General Patrol, Community Patrol Branch. But as you can see, cannabis-related offenses, or grow ops, sometimes referred to, has increased quite a bit over the last few years. And then possession for the purpose of trafficking, which is obviously a major offense. You can see that that has grown again, certainly over the last 2 years. And then simple possession. So just drug possession, it's starting to taper down. And that's kind of a good news story. That's where we want to go with decriminalization for simple possession. Next slide, please. So I basically, and I believe Jordyn talked about different countries that have implemented decriminalization. I'm going to talk about some of them as well, but we don't have to go as far as a different country. We can even take a look closer to Canada alone. And I took a look at British Columbia, taking a look at all the provinces, and specifically British Columbia, because they're very progressive in this particular area, and they had the most current statistics in regards to, for example, what I've projected here, coroner's service death review and the panel findings as of just last month, March of this year, for British Columbia. So what they basically did is they reviewed 6,007 deaths between August 1st, 2017 and July 31st to 2021. And some of the major findings of the review include, and I'm going to suggest that these are similar, these findings, and that they're not just unique to British Columbia, but we would see this right across from shore to shore in our country. For example, drug toxicity deaths continue to increase. The drug supply is increasingly toxic. Smoking is the most common method of consumption. To Darren's point, and he mentioned this during the Indigenous recognition, Indigenous people are disproportionately affected. There is also a strong concurrence of substance use and mental health disorders. Most descendants had recent contact with health professionals prior to their death. Individuals living in poverty and with housing instability are particularly vulnerable. We're talking about the marginalized, vulnerable sector of our society. Multiple substances are detected in the majority of the deaths. It's not just one particular, although I would suggest that opioid is the primary one. Very few of the descendants engaged with substance use disorder treatment services, and these deaths are occurring across the province in urban and rural and remote centers. Next slide, please. So what were some of the recommendations that came out of this panel review in British Columbia? Number one, they recommend that there needs to be an urgent need for a provincial framework for a safer drug supply distribution that includes both medical and non-medical models. Number two, an urgent need for coordinated, goal-driven provincial strategy. And this could be a 1, 2, 3 month day action plan, but it needs to be supported by the federal government with exemptions under the Controlled Drug Substance Act to decriminalize personal possession. And then third, finally, this needs to be established, or there needs to be an established evidence-based continuum of care. Regulate and oversee treatment and recovery programs and facilities to ensure that they provide evidence-based quality care and that outcomes are closely monitored and evaluated. Next slide, please. So how can we facilitate, and what are the advantages to decriminalization? Well, I'm going to suggest that the way we tackle this is through a comprehensive, integrated approach to substance use as a healthcare issue. And the next couple of slides, I've got some bullet points that I want to bring to everybody's attention in regards to how this can be accomplished. So we know that criminalization, and some of our guest presenters have already touched on this point, contributes to the stigma that drives people to use alone, which increases risk of illicit drug toxicity death. It also negatively impacts social determinants of health at the population level. We also realize we cannot arrest, the traditional model of policing. I'm going to talk about this in the next slide, actually. The traditional model of policing, which does not emphasize prevention, problem solving, but instead rapid response, reactive investigation. It's clearly not working. We cannot arrest and charge our way out of this crisis, but instead we need to examine the root issues surrounding drug addictions, substance abuse. And we know that all levels of government, that being municipal, provincial, federal, they all remain focused on saving lives, preventing substance use, optimizing the treatment system, reducing substance use harms, and improving social determinants of health. Finally, social determinants include barriers to employment and housing for people with criminal records. That's why we want to remove that stigma attached, or, for example, simple possession, if charged and entered into the judiciary system and process, they could end up with a criminal record. And this creates so many more barriers for them, in as simple as wanting to obtain employment, get a job. It also goes towards racial disparities in arrests, convictions, and incarceration for, as I stated earlier, simple possession. Next slide, please. Continuing on, the philosophy of decriminalization has been around for a few years now, as there has been a shift, as I mentioned earlier, from that traditional policing model, which emphasized those three R's, being rapid response, rapid or random patrol. It's shifted. That model has shifted to a more community safety and well-being, or what I like to refer to as a harm reduction approach on complex social disorders. And to a degree, a lot of people are not cognizant of this. Decriminalization has partially been achieved in 2020 by the Public Prosecution Services of Canada through a guideline that actually directs prosecutors, crowns, to seek alternative measures and diversion from the criminal justice system for charges such as simple possession cases. We want to look at reducing the harm associated with substance use disorder. It will take all pillars. We know it's going to take a collaborative approach, all pillars working together across the province, which includes harm reduction, treatment prevention, education, and last pillar being enforcement. And this has to be tackled through a provincial strategy. To this end, I know that the OACP, the Ontario Association of Chiefs of Police, we have advocated and called on the federal and provincial governments to invest in the necessary resources into harm reduction initiatives, such as supervised consumption, treatment sites, safe supply of drugs, and the necessary diversion rehabilitation programs to accompany any of these legislated changes. We would also suggest that the Ontario Ministry of Health and Long-Term Care should be responsible in establishing a framework and investing in that robust evidence-based treatment programs and other support services that we've been discussing here this evening. Next slide, please. Just in conclusion, and I think Jordyn touched on it when she talked about, there needs to be and I totally concur, that there needs to be a structural and societal change that just currently does not exist right now. And we need to move this from a criminal-based approach to a health-based approach, move away from criminal sanctions to administrative sanctions. And these sanctions are really necessary so that we police are equipped with the tools to address public order and public safety responsibilities while still promoting what I would suggest better health outcomes for people who are suffering from addictions. And next slide and final slide. Oh, that concludes my presentation. So be more than willing to entertain any questions or comments. Thank you.
Well, thank you very much, Chief Conn, for that really informative presentation about decriminalization. And I appreciate how you outlined the difference between decriminalization and legalization as two very different terms. And you also talked about the need for true strategy at a provincial and federal level, those complex multi-sector, multi-partner work strategies. So it takes a lot to move that work forward. We are now going to enter into our question and answer period. Questions and comments have been coming in our comment section on Facebook and YouTube, and we are very excited to answer your questions and thoughts. If I can invite all the presenters to come back to the screen, and we'll get going on some Q&As. Well, welcome back, everybody. Thank you very, very much for all of your presentations. Very informative. As I mentioned through it, I was taking chicken scratch notes as fast as I could as you were speaking. Some questions came in, and I'm going to be kind of bouncing back and forth between everybody as we talk and as the questions come up. But Jordyn, as kind of one of our first presenters that came in, some of the questions that we had from the audience were, what can people do in this community to actually help reduce stigma towards people who are using drugs and substances? A lot of times people think that this is just for the health services or just for the social services to fix. But what can people do? That's what an audience member is looking to know.
Thanks for that question, Phil. And I'm sure other panelists have thoughts on this. So please jump in, guys. But from my perspective, I think there's a lot that organizations need to do. I think there's a lot that our governments and our society needs to do, but there are absolutely things that each of us as individuals can do today and every day to help reduce stigma. And Scott talked about one that's super important, but it's person first language. That's huge. Talking about any health or social issue, we should really be using person first language. Someone's substance use doesn't define them as a whole person. There is so much more to people than that. It is one aspect of their life and of their health. Another huge piece is around practicing empathy and compassion, trying to understand where someone else is coming from, listening to their story and believing them rather than jumping to judgment and shame. Reflecting on your own attitudes, thoughts, and behaviors, challenging our biases, educating ourselves about mental health and substance use, and also educating others. So when you're having conversations with people and you hear myths or stereotypes come up, challenge those things and start a conversation about it. And learn about available resources in the community. We have Drug Awareness Council meetings, and every other month we have general membership meetings, and anyone is welcome to attend those to learn about what's going on in our community. So I think that's a good start for what individuals can do.
It sounds like there's a lot of things that the community members can take on and actually start reflecting on a lot of different practices and ways they behave and think and act towards others in our community. So I really appreciate your thoughts on that, Jordyn. And just as a reminder, we had that link down below to the Chatham-Kent Drug Awareness Council's website, as well as their phone number if you'd like to call in with further questions or comments. Building off Jordyn's comment, I want to turn over to the rest of the table. And Steph, it sounds like you have a comment on that as well.
Sorry, a comment on the same question?
Yes.
Okay. In terms of what individuals can do to reduce stigma. Yeah, so I think that from a family, I guess from our perspective at CKHA, from a family perspective and in a community, is just trying to reduce that judgment around addictions. It really doesn't assist someone in being able to reach out for help. One of the biggest things we hear from clients who come to our clinic is that it was really hard for them to come. They were nervous about judgment. And so I think that, just having an overall approach to addictions and understanding of addictions, such as attending this, will help reduce that stigma.
Very well said, Steph. And I'm going to turn over to Scott as well, because Scott, I think you talked about this heavily in your presentation on harm reduction, the philosophy behind it, and the way we want to treat people in our community. So, Scott, what are your thoughts on this question as well?
I thank you for bringing that back up for the touching it off my presentation there. But I think we have to look at it as a trauma-informed lens, where people are coming from a place where they're being hurt, and when they're hurt, they're not themselves, and we need to make sure that is taken care of, looking at the whole person and not just their use. Jordyn talked about that. Those are really important, kind of erasing that barrier that stands between people, and just be authentic.
Very well said, Scott. I mean, it's really, I'm not sure if I'm speaking out of turn, but it's kind of easy to be scared of what we don't know, and taking that time to get to understand what's going on, understand people and the way they're living, what's going on for them, is a really important aspect of this. And I think you just said it, where just be authentic, just be yourself. People are people, humans are humans. So I really appreciate that comment, Scott. Building off that concept of harm reduction and stigma, Chief Conn, you mentioned that the concept of decriminalization for you is kind of like another way to do harm reduction. It's a part of harm reduction. And I'm wondering if you can speak a little bit more to how decriminalization is going to help us stop putting barriers in people's ways. As you mentioned, there's a lot of barriers that happens with criminalization around substances. So I wonder if you can speak a little bit more to those barriers that could be removed if we decriminalize personal use.
A lot of those barriers surround prohibited grounds, right? So we want to remove those barriers, and I would go back to what Scott said about being authentic. We have to guard against viewing this through a myopic lens. We have to keep an open mind and look at different avenues to mitigate these issues, because clearly what we have been doing in the past, it's not working. It's not. It's just getting worse, and this affects everyone. This has an impact at a societal level. And I think, well, there's a multitude of different ways we can go about in mitigating this, but I think it surrounds education, it surrounds prevention, problem solving, and finally, looking or tackling this through a integrated multi-sectorial approach. It's going to require that collaborative effort. Not one entity or one body is going to fix this. It's going to require everybody. That's police, health, paramedics, everyone, all other social services which assist us on the day-to-day basis in not just drug addictions, but what I refer to as complex social disorders. And that deals with not only drug addictions, mental health, poverty, homelessness, all of those things that 80% of our calls for service deal with on a day-to-day basis. A lot of people think that it's quite the opposite. 80% of our calls for service are criminal in nature. No, they're not. Only 20%, 20 to 15% of our calls for service are criminal in nature. It's those complex social disorder calls that primarily absorbs, or I should say, draws upon our resources. at a community-based level.
Very well said. And I think just carrying on forward, we had a community member share or ask a comment or a question for yourself, just to carry on that point. Do we have to wait for the province, the federal government to start any of these initiatives, or what can we do locally here in Chatham-Kent, such as, for example, safe consumption sites, or how can CK or Chatham-Kent take the lead on this?
Yeah, that's a great question. Absolutely. And things that we're working on every day. Locally, I would refer to what was just provincially mandated, as a matter of fact, just last year, our community safety and well-being plan. That brings together all those social services at addressing issues that are locally identified, because what might be an issue in one region, for example, let's say in the GTA area, is not necessarily an issue here in predominantly rural Chatham-Kent. The unique thing about our municipality is we've got a blending of both urban and rural, which presents its challenges and its difficulties, which are unique to other municipalities. But the development of our community safety and well-being plan basically consists of 3 priority focus areas that we identified as most prevalent in our municipality. And that was, number 1, community awareness and integration. We've got to get the message out as to what services, what support mechanisms are provided locally here in Chatham-Kent. So that's number 1. Number 2, priority focus is mental health and substance use. We've got to develop and maintain a municipal drug strategy, and that can be by simply enhancing some of the services that are provided here today, and a lot of them were mentioned. For example, RAAM, I apologize, MHAP, trying to get the acronym down correctly, and also the withdrawal management service that is provided through Chatham-Kent Health as well. And then finally, what we've identified as an issue locally here is obviously, and I know most of your listeners are cognizant of this, but housing and homelessness. So those are just some of the ways that we're trying to tackle that locally here. But we want to continue to still lobby and advocate with the provincial and federal governments, because let's face it, they have deeper pockets than we do in being able to support a lot of these services that we're mentioning here today.
Absolutely. Thank you so much, Chief Conn, for those remarks. And I think that's a great connection to some further viewer questions that come in around the RAAM clinic. So I'm going to turn it over to Stephanie now. Stephanie, when we talk about the RAAM clinic, it is it provides a variety of different services and supports. The rapid access to addiction medicine clinic, if I'm not mistaken.
We have a lot of acronyms, but yes.
Yeah.
Good. I was wanting to make sure I had the right acronym. And so I have somebody who's reaching out asking, what does a first appointment look like for someone who's never been to RAAM before?
Sure. So the first appointment is really tailored to the individual who's seeking services. There may be a bit of a wait time. We try to get to individuals who are coming into our service as quickly as we possibly can. But if, for new individuals come at the same time, then it might be a little bit of a wait. So just prepare that it could be a wait time. And then they would be seen, depending on what their goals are, they would be seen by either the therapist or the RN first, who would complete an assessment, get kind of a history of what the substances are that they're using, and then start to ask them about what their goals are with substances. If they're looking for an abstinence-based approach, if they're looking for harm reduction, if they're looking for just support and they're not quite sure what they're looking for yet. And then based on those answers, they would see the addiction psychiatrist to talk about medication options. They would be booked for a gains assessment to talk about a referral to treatment if they wanted to go to an inpatient rehabilitation center. and we would refer them to other services depending on their needs as well. So that first appointment would really be that time that we can try to assess what they're needing, what they're looking for, and how we can connect them with those things.
Okay. It's good to know. And I wonder, with the referral process, we've had some community members ask questions or comment around the fact that there's a long wait list for other programs that you might be referring to, and not just through RAAM. There's a variety of other organizations that do referrals in the community, but there's long wait lists. And so a lot of people are asking sort of what happens for those individuals who are referred to maybe inpatient treatment or maybe psychotherapy or counseling. It's taking a month or two to get on or into service. What opportunities they have to access supports during that waiting period?
Mm-hmm. So from an addictions perspective in Chatham-Kent, that really is the need that our RAAM clinic has been trying to fill. So we do still carry a wait list, especially we're a little short staffed right now on our therapy side, but we carry a wait list for addictions therapy. But those individuals can present to the RAAM clinic throughout the week and talk to also, the same type of therapist that would be in the other program. So they're a little bit shorter sessions, but they're just more kind of solution focused on one issue or a couple issues. So we do offer that therapy service through the RAAM clinic in order to meet that addictions therapy need for that piece. I do see that there's a reference to the long wait for rehab. And I share that frustration. We share that frustration at CKHA. For us, it's very difficult to have a client who's ready to go and who we support, and we can't get them anywhere. For one, until they complete a fairly long assessment, and for two, until they can kind of jump through the hoops to get to treatment. So, they have to, most facilities do weekly check-ins, and you have to be calling regularly to make sure that you're still wanting to go there and all those things. So we do try to support clients as best as we can. Our therapist at the RAAM clinic stays in touch with clients throughout this period. She's able to text with them. She's able to call them. They're able to call her. So there is a lot of communication there and support that we try to offer, but again, it's a provincial issue in terms of the wait for treatment.
Understandably. So, I mean, these are multiplex challenges that we're facing here, and it's as Chief Conn kind of spoke to, we are investing as much as we can locally, but this takes other levels of government as well as other larger groups to be involved beyond our community as well. This is really a national piece and provincial piece as well to this. So I appreciate your thoughts on that, Stephanie. Last question I'm going to ask you, Stephanie, around just the RAAM clinic is I'm wondering if the counseling component, there's some questions that came in around there's a maximum of 12 sessions for counseling, and after that, what happens to those individuals who might need more sessions in that area? And so I'm just wondering if you could speak a little bit more to that piece.
Sure. So I guess a little bit further on those sessions is that those are 12 publicly funded free sessions, which compared to other cities within Ontario, we actually have a higher offering compared to a lot of areas of free sessions. So 12, we really try in our program to make it goal-oriented therapy, which means that you would come into those 12 sessions with certain goals that you're looking to achieve, and your therapist would partner with you in a holistic way to try to address mental health and addictions concerns to the best of their ability within those 12 sessions. That being said, individuals, we do promote after those 12 sessions that individuals kind of try to put those skills into practice without a therapist, and we have other supports available, which I'll talk in a minute, for a period of time, but they can also be re-referred either right away or fairly quickly back and do another 12 sessions if they need that, if that's what's deemed kind of appropriate for their case. So we do have that 12 session limit for one time, but if they end up needing more support in the future, then we do offer that support. The other thing is that we involve community agencies. So for example, we practice from a trauma-informed care perspective and focus on the stabilization of trauma, something called stage 1, but that's kind of a different topic. So after that piece, if individuals are looking for further trauma intervention, then we would also refer to Family Service Kent. If we're looking at longer term mental health issues, then we would refer to case management, perhaps at CMHA, and a variety of other services. So we definitely don't, to the best of our ability at that last session, just say like, see you later. We try to make a plan. We support the individual. We do the best we can to make sure that they're not just left with nothing.
Well, thanks so much, Stephanie. I mean, that's a really important piece. I think there's about 3 or 4 people asking about that. So thank you for answering that question. I know I know there's more questions to ask. I know there's more people who are probably asking questions as we speak. Unfortunately, everyone, we are running quite past our 7 o'clock end time, and we do have to sign off. But what I usually like to do before we sign off is just a 30-second, if you could say in 1 or 2 sentences, what is the takeaway from today's presentations and today's conversation. Give me 30 seconds worth of knowledge. Jordyn, I'll turn it over to you. What's the takeaway?
I think I heard a lot about working together to improve the health and well-being of our community. We need to collectively recognize that substance use is a complex human behavior, and then really move beyond that acceptance and focus on what really matters, and that's managing the risks and harms related to substance use, promoting the factors that we know strengthen the resilience of individuals and our community.
Fantastic. Thanks so much, Jordyn. And Scott, same question to you. Takeaway for today.
Takeaway for today, we have to listen to the people we're serving. We have to make sure that their voices are heard, they're validated, and we have to make sure that they feel that we're accomplishing something with them, not for them.
Very well said. And Chief Conn, I'm going to turn over to you. What's the takeaway from today for yourself?
For me, certainly surrounding drug decriminalization is that it triggers an immediate need for, as I stated earlier, that structural and societal change, or at least being receptive to that. I mean, we can agree to disagree, but as long as we're working to resolve the same problem, then, we're going to get some traction in regards to this. And in obtaining traction towards mitigating this is going to require that multi-sectoral integrated approach from all sectors.
Very well said. Complex issues, complex challenges, and complex solutions. Thank you very much, Chief Conn. And Stephanie, yourself, what is the takeaway from today?
I think just the importance of community connection and engagement and information. I learned, I'm in this field and I work with these individuals, and I learned lots from this presentation. So I think there's lots of knowledge in our community that can be shared. So that would be my takeaway.
Perfect. Well, thank you so much to all 4 of our presenters, Jordyn, Lindsay, Scott Roose, Stephanie DeVitto, and Chief Gary Conn. For those who are watching, thank you very much for watching. It was an absolute pleasure. Thank you for your questions. Again, this was Chatham-Kent Drug Awareness Council's presentation on what we know about substance use. Their website is below in the chat, as you can see. Chatham-Kent Drug Awareness Council can be found at www.ckdac.ca, and their phone number should be popping up as well, 519-354-6221, extension 241. Thank you, everyone, for a great presentation, a great live Facebook Live, and we'll see you soon with another presentation. Have a good night, everyone.
Stay safe.